All right, so technology is great except when it's not. So we're going to try it this way. So I apologize if the videos don't work, but that's okay. So my name is John Tiss. I'm a member of the pediatric division of orthopedics here. And what we're going to talk about now is, and I'll say in full disclosure, when I came here 7 years ago, I didn't have a big interest in patellar dislocations. When I was treating young adults when I was with the military, we didn't see that many patellar dislocations, so it wasn't a big interest. But if you see kids, you're going to see a lot of these, and so it becomes an interest of yours when you start seeing a lot of them. So just a brief outline, we'll just quickly go over the anatomy, how we define dislocations, physical exam, imaging, then which patients do you need to refer and which are you okay with taking care of, and then also what you do for non-operative treatment, and then just a little brief overview of what we do for operative treatment. And just real quickly, so how many people here have seen a patellar dislocation in the last month in their office? No, not seeing too many hands. Okay. So if in adolescence, it's actually the incidence is fairly high. And that's where Jay and I see most of ours. And the incidence per year is 29 per 100,000. And whereas in the younger child population, it's not nearly as high. It's 6 per 100,000. But that's per year. And the other reason it's important is because if you don't treat it, number one, you're going to have the immediate disability, or if you don't treat it optimally, you're going to have that disability. You're not going to be able to function as well, and they're going to miss time out of school. But then the other thing, the picture here is, what you're looking at there, that's straight bone. And it's probably, if you just took this out of context, you say that's probably like a 70 or 80-year-old knee. But this is actually the knee, I think she was 12 or 13. And all the cartilage has been rubbed off it, and that's bone. That pink stuff is complete bone. So she's used up all the cartilage for her life. And this was from untreated patellar dislocation. She kept dislocating since the age of 5, and that's what happens over time. You wear away the cartilage. So it's good to learn how to treat it properly. So the osteology, the bony anatomy of the patella, and this is what leads to your dislocations and the direction of dislocations. You notice it's shallow here, a little steeper on this side. This is the outside, this is the lateral side, medial side. So the patella pretty much always goes out to the outside, and that's why. It's because of that bony anatomy. So that's where you're going to see it go. Okay, if the patient tells you it dislocated to the inside, you got to be thinking something else. The only time where I've ever seen it dislocate to the inside, or heard of it really, is on someone who's had previous surgery, has been over-tightened or whatnot. So it always goes to the outside. So moving on to the ligamentous anatomy, so you have the patellar ligament, which a lot of people call the patellar tendon, and then you have your quadriceps tendon up here. And the important thing here is the ligament attaches to your tibial tubercle, and if this is too far to the outside, the patella just goes right out. And that's important to recognize in your anatomy because there's variations among normal. But if this is too far to the outside, it predisposes them to come into the outside. Then we move on to the muscles, and the one important structure over here is there's one ligament on the medial side which is countering all these bony forces and everything, and we just call that the MPFL, or the medial patellofemoral ligament. So that poor little MPFL sitting out there has a lot of work to do to keep that patella from going to the outside. So that counters that force. So when the patient comes in, often they will tell you, my knee's dislocating. And really what they mean is that their kneecap is dislocating, okay? Because it's pretty hard to dislocate a knee. So it's really their kneecap. And often it's not really dislocating. Dislocating is when it completely comes out of the joint, Whereas subluxing, it's just kind of riding to the outside. But that may bother them. But that's a different treatment. It's a whole different pathology. So if it's just kind of riding to the outside, but they don't know that difference. So they'll tell you, oh, my knee's coming out of place. But really what it's doing is it's riding to the outside. So, we just call that subluxation. And then the other thing is, it's important to recognize, does the child have a syndrome? Most commonly, it would be like a Down's child, and they're very ligaminously lax. There's lots of syndromes out there where they're very lax, and you have to recognize that too, because that'll contribute to either the patient's failure or success. So some other considerations are, was it an acute sports injury, which is how I see most of them, and probably if you're in a community like most of them are now with these year-round sports, that's where you're going to see most of them. The other are the chronic, like the girl I showed the slide before, just been dislocating since age 5. And in those chronic ones, especially if there isn't a known history of trauma, you need to consider anatomic considerations, which like is that bony part of that anatomy pulling to the outside? Are they rotated? How's the alignment of their leg? Because there's probably something in their anatomy that's causing them to dislocate without a trauma. But luckily, the vast majority of them are from a sports trauma. And then finally, the last considerations is how severe is it? Is it just subluxing? Is it dislocating? Is there pain? Do they have arthritis? Because some of these kids by their early teens even have some arthritic changes. So you have to recognize their pain because that's something they're complaining about. So the acute injury in the athlete is usually a non-contact twisting injury with the knee that is an extension. So they'll rotate, the patella will dislocate to the outside, and then often it spontaneously goes right back in. So they'll take another step, they straighten their knee, and it popped right back in. Sometimes they say, their coach straightened it out. Other times they have to go to the emergency room, but usually all it takes is straightening out the knee, and then it pops back in. So for the chronic one, you want to recognize, okay, was there a remote injury? Because there's a big difference between the ligaminously lax child who may or may not have some syndrome. Maybe she has something like Ehlers-Danlos, something, very ligaminously lax, who never really had a trauma, and her kneecap has been coming out for years, and the child who, when they were playing travel team soccer at the age of 8, twisted their knee, and it never came out before that. And then ever since then, it's been coming out at least once a month. And now she's stopped playing soccer because she just doesn't like it anymore because, it hurts too much. So there's a big difference in that history. So the history is really important. Other things you want to specifically ask about are, does it lock or catch? So you want to find out, is there something getting stuck there? Does it lock or catch? Do you feel like something's floating around there? Okay, and is it swelling? Okay, so that indicates some more serious injury. And then you want to ask them if they had previous surgery, although just looking at the knee, you'll be able to tell that, usually from their scar. Other things you want to think about when they say that their kneecap came out of place, so maybe their kneecap did come out of place, but they may have other injuries as well as ACL, anterior cruciate ligament, PCL, posterior cruciate ligament, medial collateral ligament, all the other the ligaments, meniscal tears. But number one, make sure they don't have a fracture, okay? Because just last week I saw a kid who was diagnosed with an MCL tear. So for 2 weeks he was treated with MCL tear. It turned out he had a fracture. And so you want it, because the fractures you got to fix right away. So get an X-ray. If you got a question about it, just get an X-ray. That'll rule out a fracture. Okay. All right. Physical exam. Big believer in physical exam. Really important. And in some cases, you have better sensitivity and specificity than even MRI. Okay. So you gotta at least look at the patient, put them through a range of motion, look at their overall alignment, and then do some of the specific tests. And again, this is my plug for physical exam. We all learn the inspection, palpation, percussion, auscultation. Well, almost all of them. Maybe not percussion for this, but each of these is important. And you want to be systematic, so on each patient, I think it's really important to do a full exam on them all and then focus in on some specific tests. So alignment. So the first thing I do as they're walking in, I watch them as they're walking in down the hallway in the clinic, and I look at their alignment. And in the normal child, and especially most of these are going to be girls, you're going to have a little bit of valgus. So the tibia is going to be coming out from the knee a little bit. So over here on this side, that's someone who's abnormal. They're a little bit bow-legged or in varus. But that's the first thing you want to look at. You also want to look as they're walking in. Are they limping? Okay. And then when they come in, you ask them how they're doing. You get your history. And then when you start the physical exam, ask them to take one finger and point to where it hurts, if it hurts. And so this is just walking down the hallway, a normal exam. Okay. So the next thing you want to look at is there, what's an effusion? An effusion is fluid underneath the kneecap. Okay, so it's fluid in the knee joint itself. And that's different from a bruise. It's different from banging on the side. So when you push down on the kneecap, does it float up and down? And if there is fluid in the knee joint itself, if there's an effusion, that means there's a serious injury. There's either a fracture, an ACL tear, a meniscal tear. There's something that we need to look at. And if we're not diagnosing it, we need to look a little harder. So whereas just a regular bruise or something, okay, well, that may just take some time. All right. The next thing I look at is range of motion. If they don't have full range of motion, something is wrong. And most kids will be able to fully extend or even hyperextend 5 or 10 degrees and go up to at least 120, 130 degrees. Some will even get up to a lot further than that. Okay. I don't know if, so this is, your first, yeah, I don't think our videos will work doing it this way, so sorry. So, but this is basically doing the range of motion. All right, so what do you do with x-rays? So you're going to start with just a front view and a side view, okay? Usually the side view you get in about 30 degrees of flexion. You can do different, but at least get an x-ray, a front view and a side view. If you think that there's a problem with the kneecap, they said, oh, my knee came out of place, or they're pointing there, or whatever reason you have, you're going to get something called a merchant view. And the merchant view is pretty easy to get. Nowadays, you can go on the internet, you can Google merchant, you can send the patient, print this out, send them to the x-ray place, although every x-ray technologist knows how to do this, but sometimes it's better safe than sorry. And all you do is you just point the beam down there, and there's the x-ray plate right there. And this is the view that you come up with, and you see the kneecap and the groove right there. And that's important to look for fractures and also where the kneecap is. Okay. The other thing is, this is the other knee x-ray I like to get. So in everybody who comes in with just knee pain, get this knee x-ray. Obviously, I'm being a little facetious, but it'll happen. It'll happen that you're fully focused on their knee, and then someone smart in the office comes in and says, oh, Dr. Tiss, did you look at their hips? Oh, of course. And then you get the hip x-ray, and that's what you see, is you see the skiffy right there, which is a slip. So beware of the patient who comes in with knee pain with the hip. So almost always include that unless there's something really, really obvious. All right, so CT. Does CT play a role? I will tell you my opinion here. I don't, in my practice, CT does not any longer play a role here, a very limited role, I should say. Some individuals would use this to look for the rotation, the alignment, but really it's pretty high radiation, and really everything that you need to look at on the CT, you can get on an MRI if you need to get it. So I don't really use CT any longer. When do you get an MRI? I would leave that, like Dr. Sponsor was talking about before, with